Good evening. In the late 1800s, Frederick Adolf Trendelenburg discovered that if you tilted surgical patients head down, the gravity shifted the abdominal viscera and opened up the visual fields to surgeons. During World War I, Walter Cannon, a groundbreaking American physiologist, suggested using the position as a way to autotransfuse blood to those who were experiencing hypovolemic shock. Cannon retracted that statement 10 years later. However, in the short time the procedure known as Trendelenburg positioning had caught on and become an ingrained habit with healthcare professionals. As early as the 1960s, it was determined that the position actually posed a significant risk of detrimental side effects when used. Yet nurses and physicians continued to use this response. Working in a busy trauma unit, I noticed the often instinctual use of this process on numerous occasions and was surprised to hear nurses' accounts of it being taught in nursing school. Based on this, a PICO question was formulated. Patients in hypovolemic shock, placed in Trendelenburg positioning compared to those who are not, may suffer harmful effects. A literature search was completed, 5 articles were selected and critiqued for relevance and biases. All 5 articles suggested a transient autotransfusion effect did occur with Trendelenburg positioning at the 1 and 5 minute markers. However, cardiac output returned to at or below the initial measurement by the 10-minute mark. The thought process was that by tilting the patient, the baroreceptors in the carotids were being placed below the level of the heart, thereby receiving the message there was more intravascular volume than was actually present, and thus failed to trigger the chemical response to shock. This potentially resulted in bypassing the compensatory phase of shock and heading straight to decompensation. Also noted with the positioning was other potential serious side effects. When positioned at 10 degrees or greater, the shifting of the abdominal contents put pressure on the diaphragm and the vena cava, decreasing vital capacity, thereby affecting ventilation and perfusion, increasing the risk of atelectasis, decreasing cardiac preload, increasing cardiac oxygen demand in cardiac patients, and resulting in dysrhythmias. Tilting patients was also found to increase intracranial pressures, increase intraocular pressures, and decrease lower limb perfusion. Intubated patients were at risk of higher interpulmonary shunting and shifting of the ET tube to the right main bronchus. Margaret Halm states, Trendelenburg is an example of an intervention that is based on tradition rather than scientific evidence. So how do we go about changing this age-old habit? Johnson and Henderson suggest the ritualistic use of Trendelenburg position by pre-hospital and hospital staff is difficult to reverse, qualifying it as one of the many literature-resistant myths in medicine. Based on a suggestion by Margaret Halm in changing the process, I did a survey of nurses through local Facebook nursing sites. Of the respondents, consisting mainly of RNs and a physician and a few NPs and LPNs, 87% reported using the Trendelenburg position, with 59% claiming they use it for shock. Of the 70% who were aware of the potential side effects of the position, 14.5% continued to use it out of habit, peer pressure, or they disagreed with the literature. Overwhelmingly, 85% reported that they had learned this procedure in nursing school. Armed with this information, my intervention is to cease the use of this position in our area by targeting the educators at the local university level, using a TED Talk type podcast and distributing it to the local university educators, as well as to seek publication of my findings in the nursing journals such as Critical Care Nursing. O'Leary suggests the use of podcasts as one of the most influential, accessible, and widely distributable education tools of this time. Cotter also suggests in his 8 stages of change that reinforcement is the key to ensuring change, and I am hoping that by targeting educators and stopping the process before it begins, we will observe a ripple effect. One can hope that those who adopt the knowledge and cease the behavior will influence the others in their department. Thank you.